have a live set during today. There is no patient, so I will show you quite a live surgery because it's a rush, okay, and we will have a discussion. We can go on and so just for the position of the patient, we'll start. This video was done here in Strasbourg. Introduced. So the position of the patient is the two arms are along the body. It's very important, and you place the patient in tender position at the very beginning, just to help the bowel to go in the cavity and to empty, in fact, the pelvis floor. Okay. Also, you have to have an easy access to the vagina. I mean that the bottom of the patient must be at least 5 centimeters above the end of the table to be able to mobilize the blade. You see the blade, it's a metallic blade. We need to place on it a glove just to avoid to have a contact when you are doing monopolar scissors, to avoid to have a metallic arc, okay? Just to protect. And you see the position. So immediately, when the draping is done, immediately you place. Then during the preparation, the bowel are going inside. So we don't give any preparation for the bowel. It's just standard. So for the beginning, it's you do as you prefer. We use various needles, but you can do mini open surgery. Okay, and we place the first port. It's a 10 millimeter port. And after, we used to place only 5 millimeter ports, just to have your instrument really with the same ports, 5 millimeter ports, to avoid to have mobilization in the 10 millimeter port. So you will pass through the 10 millimeter ports at the level of the optic, the mesh in the needle. Okay? It's just a little movement. But it's very important because it's a long time of suture, and if you are not really with good instrument, if you have a movement in the ports, then you are less precise. So you see the 3 ports. So you have to place your port really laterally to have a good triangulation. So we will start now by the fixation. You see the fixation. So for the fixation, we use a straight needle at the level of the pubic bones, really as down as possible, and you fix it through the skin with a little grasper. And I use to fix again also the sigmoid loop to have a very good exposure. So for the sigmoid loop, the level of the fixation is the round ligament. You see the needle is already placed. And now what you have to do is just to look at the sacral ligaments and to look at the fatty part of the sigmoid loop at the level of the sacral ligaments and to fix it. Then you can see that you have a very good exposure, and you won't see anymore the bowel. So for the surgery, the first thing, you start really medially, and you don't need to have a suction device for this surgery. It's only anatomical lumbar. Okay. So what you have to look when you find the ligaments is to look at the typical aspect which is arachnoid space, and you follow the gas. The gas will help you. The second landmark is to go towards the uterosacral ligament on the right side. Okay, you see this arch, just with the tension, you let the gas get inside, and you have just to do an incision like this. And you see this typical aspect. Okay, just tension, you let the gas get in, and you follow the gas. Look, just push away, and you look, you just follow this layer. When you have little vessel, you do a little coagulation, but most of the time there is quite nothing. At that time here, it's very important to pay attention because you have the crossing with the ureter. So I will show you. Here we are. you see this large and deep incision, because it will help you. So I will just show you. Very deep incision, it will help you for the peritonealization at the end of the surgery. If you just do an incision as a peritoneum, at the end it's impossible to close it. Here you see the uterosacral ligament. You see the ureter is here. Most of the time you go outside of it. If you go outside of it, then you are at risk to injure the ureter and also to have a lot of vessel here and it start to bleed. So the situation is when you have the uterosacral ligament, you go inside. Okay, you inside towards the Douglas pouch. Okay, if you turn like this, then no risk. And in fact, you will detach the peritoneum from the uterosacral ligament on the right side. Just so promontory towards the sacral ligament, and then you just turn. And it's a okay incision in. So look at, you see the ureter, and so here you do the incision just under the ligament. You see, okay, the incision is done, and now you arrive at the Douglas pouch. Okay, at the Douglas pouch, you have always what you are looking for is the gas. You see the gas again. So you finish the dissection, and you will do incision from the right uterosacral ligament to the left one. Okay, it's a large incision. And at the very beginning of the dissection, I used to avoid to place the blade, and then you will place the blade. You see the blade here. But what is really important is to go as high as possible, to very close to the blade, to be as far as possible to the rectum. Okay, and you see this space. Typical. You have to look at this space, and just at the beginning, you just stay medially. Okay? And what is very important to imagine, you place the blade in the posterior cul-de-sac, okay? Not anterior cul-de-sac, because if it's anterior cul-de-sac, you will have the cervix, and you can't see. So you place the blade in the posterior cul-de-sac, okay? And you will ask your assistant to lift up the blade as maximum as you can, because your scissors has to be parallel to the blade. If your blade is like this, you can't reach the pelvic floor, okay? If your blade is like this, then you will be able to follow and to reach the pelvic floor. So you will see now the movement of the blade, which is very, very important. So sometimes you have to replace the blade. You see now that the scissors is really parallel to the blade, okay? So you go as deep as possible, and you stay medial at that time. And when you reach the end, then you will go on both sides to find the levator animus. I will show you in another video. And what is important is to really do the dissection as deep as possible, to avoid to detach all the vessel coming from the rectum, and because if you start to dissect all these vessels, you will have bad vascular vascularization of the rectum, and you will injure the nerve of the rectum, and you can have constipation, terminal constipation. You see this aspect of the end of the rectum and this fossa on both sides. And when it's really well done, you have this typical aspect with like a face with the two eyes and the nose inside. Like when if you see this aspect, this is a typical aspect. You see, and you see the importance of the blade. So now we introduce the mesh through the 10mm ports. Okay, the mesh is previously prepared, cut, and the thread is on it. The thread is a non-resorbable thread. It's a mersuture 2O with a 26 needle. It's a round needle. It's not a sharp needle. Okay, and I'm left-hander, so that's why I'm doing it with my left hand. Okay, and And you see that what is important at that time, the mesh, the blade is as maximum as you can, lift it up, okay? And then you reach the levator animus. So here on the left side, you see the rectum, so we are far from the rectum, okay? And we just want to place the mesh in contact with the levator animus, and it's like a herniorrhaphy, in fact. So you have to imagine that prolapse is like hernia, okay? So you just place a mesh in between the vagina and the rectum, and it will be sticked slowly, and it will correct the prolapse, okay? If you have a big rectal cell, you will add another point on the rectum, but you see on the right side, exactly the same. And what is really important is the position of the blade. Here you don't see anything because the blade is well placed. If the blade is not well placed, you can't do this stuff. So these 2 points are the most difficult one because it's really deep. Here it's polypropylene mesh. You can place a polyester mesh. I will show you another video. So here you can add, if you have a big rectus, you can add a median pole to fix it to the rectum, okay, or to the vagina. Now the second step is to fix the superior part of the mesh to the uterosacral ligament. Here you have to pay attention to be not too deep, to avoid to be transvaginal. Sometimes if you want to have a very large point, you will be transvaginal. And if you are transvaginal, the risk is to have an ulceration several months or year after. So pay attention to this. I will show you complications in a few minutes, and this can be a complication. So you can see here what is important is the mobilization of the blade. You ask your assistant to mobilize the blade and to see very well where is the ligament. You see the blade, you see the vagina, so not too close. This is too close, okay? You see here, and then just take really the sacral ligaments and not too deep, also because the uterus is so not too large, not too deep. So it's really precise, okay? If you have well done your dissection, it's okay. The idea is just to imagine that the mesh will stick to the vagina. So just place it, okay? Okay, you see now this aspect. The rectum is not compressed by the mesh. That's very important. At the beginning, the very beginning of the surgery, we are doing another fixation. So for the posterior time is finished. Before starting the anterior time, I prepare the peritonealization. Here it's vitral. It's a 3O or 2O vitral. It's 26 millimeter needle, and I start to close the Douglas pouch, okay, by a running suture, starting by the left uterosacral ligaments, closing the Douglas pouch, going back to the right uterosacral ligaments, and going back. And then it's a running suture, and it will close totally the Douglas pouch. You see the Douglas pouch is closed, and it remains only the thin part of the mesh going towards the sacral ligaments. Okay, so you see now it's closed, okay, and this thread I will let it in the field. I will do the anterior part, and at the end I will retake this thread to finish the peritonealization, because sometimes it's difficult to finish the peritonealization while the two mesh are fixed to the sacral ligament. So I prepare. You see, I will look where is the best way to fix it. I prepare this, and this thread will be let in the field. Okay, now it's time to the anterior dissection, and at that time I use the fixation of the uterus. The uterus is still fixed anteriorly, and I am doing a passage through the large ligament, okay, on both sides. Okay. The landmark is to start just under the ovarian ligament. So you see the ovarian ligament, and you just look at the passage just under it. Okay? And you let the gas get inside. And when you have done this on both sides, So you will see that anteriorly, in the radius space, you have already, you see here, you have already the gas. So in fact, the dissection is already done. So now you release the fixation of the uterus, okay? And you see that now the gas is already placed, so you give to your assistant the uterus. I will just lift up, and I will have to do an incision of the peritoneum, and I will find immediately my two holes already prepared on both sides. At the very beginning of the dissection, we won't place the blade. I start to push away the bladder, and then few minutes after, we start to place the blade. So now you see the blade, and now the blade is placed in the anterior cul-de-sac, okay, and not in the posterior cul-de-sac. So pay attention to this. And the blade, now you have to ask your assistant to place not the posterior cul-de-sac and lift up, but now down, to open the space between the blade and the bladder. So you are going to lift the bladder medially. My hand is here. The blade is going to be a little bit down, and then you follow the blade. Okay, so your assistant is very, very, very important. If the blade is like this, you can't dissect the bladder. Okay. So very, very important. And so be careful, because sometimes the cervix is very large, and if the blade is posterior to the cervix, you don't understand because you are not in the good situation. Okay. Or sometimes you have myoma, big myoma in the cervix, and sometimes you don't understand what. So don't hesitate to do vaginal examination to say, oh, it's not normal, and to be really in the good situation. So you see now the blade, we'll ask the assistant to place it a little bit down, and now you see this space is open, you see the blade, and you just push away. This surgery, in 99%, I won't take any suction device. Okay? 99%. Because there is no, if you are in the good layer, there is no bleeding. You see? Slowly, you go on. And at the end, you will ask your assistant to mobilize the blade laterally to see the lateral aspect of the blade. You see the distance, and to see here the lateral sister cell. When it starts to be difficult at the end, you are in fact just below the balloon, and you have to start to stop your dissection, because if you go too deep, then you will be at risk to have instability of the bladder, because you dissect under the trigona. So you have to stop. Now we introduce through 10 million ports the mesh, and the difference between the technique of Thierry, that you will see that the mesh is recut in two legs, because I will place my mesh through the two holes in the parameter. Okay? But except this is exactly the same technique. Okay? And here you see the first point is really medial and as superficial as you can, and really the fixation is only with the vagina. So you have to pay attention here to avoid to have a big point with the vagina and the bladder and the mesh. Sometimes you have this kind of points, and if you have this, you are at risk to have a fistula. So you see, it's only the. Now we go laterally on the, and at that time, the assistant is doing a mobilization of the blade to see the lateral aspect of the vagina, and again with this kind of thread, which is a 2O mesh suture, you fix it. You see this aspect, you see very well the lateral aspect of the blade and the lateral aspect of the vagina, so it's just exposition. And you see that now there is really no fixation of the mesh with the bladder. It's only the fixation with the. Here we are at the pipe part of the mesh, and here it's very important to fix the mesh really to the anterior cervix and to the isthmus of the uterus. So this point is really, really important. It must be a deep point, minimum half centimeter, because we saw that this is the most important point for the fixation of the uterus, to avoid to have a prolapse of the uterus. Okay, so here is on the opposite side, on the left side, the superior part, so mesh, then anterior cul-de-sac of the vagina, and then isthmus of the uterus. You have not seen this third point, but it was a point. Now I will place the two mesh on both sides. You see, we have done the passage through the ligament. So first leg on the right side. Okay, second leg on the opposite side. So you have seen with the technique of Thierry that you can do only a passage on the right side. It depends on your habits. When I was doing this surgery 20 years ago by open surgery, we were doing like this. That's why I'm doing still this technique. And you see this typical aspect. Okay, so now it's time to fix the mesh to the sacral ligament. Okay, you see the sacral ligament. So in fact we have like three mesh. It's in fact one mesh and the two. So we start by the posterior mesh, which is a large one. So because I'm left-hander, I'm doing it from the left to the right, but for you it's exactly the symmetric thing. So first thing is to fix the large mesh, and then you have, so for the fixation of the mesh, what is important is to avoid for the posterior one, for the posterior mesh, you don't place any tension. You just place it as it goes. If you do tension, you are at risk to have a big constipation. Just place it. For the anterior mesh, you have to do contraction for the pneumoperitoneum. So you just do a little traction, or you help you with a blade if you prefer. Personally, I take out the blade and I just doing a little traction to do a contraction to the pneumoperitoneum to be sure that I correct the cystosis. Because if you just let the place your mesh as it goes with the pressure, in fact, you have still the cystosis. Okay, so you have to do a little traction. So you see it on this video. This is this little traction. Okay, I'm looking to the anterior aspect. My assistant will grab the mesh. Okay, this is the left part of the anterior mesh, and now I have to find the right part of the anterior mesh, which is here. You see it, and you see the tension. I'm looking to the tension, and I'm looking if it's okay, and then I'm looking where it is. And here I will do an extracorporeal node. If you want this afternoon, I can show you in the lab. You will see. It's a Roder node, or magic node, you will see. It's an extracorporeal node, and you just have to do the tension on the node, and then you will see it goes directly to the. With a pusher, you finish, and you just add a loop to block it. So I like very much this node because there is a little tension on the mesh. Sometimes it's difficult to do it. So if you want this afternoon, you ask me. I can come to see to show you how to do it in the lab. Okay. Now it's quite finished. You have to recut the excessive length of the mesh. Okay, and we have to do the peritoneization. Remember that we have placed already the vicral thread here. We have closed the glass pouch, so we have just to take the thread here. You remember, okay? The thread is here, and now I will close on both sides. So first, the window in the large ligament on the left side. Then fixation to the isthmus, then the window on the right side. And then the posterior aspect of the peritoneum. The the ureter is much more lateral, okay? And when you have done this, in fact, all the peritoneum will cover totally the mesh, you will see. It's really important to do a good peritoneization at the end of your surgery, because if you don't do it, you are at risk to have an occlusion, because you can have the bowel going in contact with the mesh. So pay attention on this type. And you see, because I have done previously a large and deep incision of the peritoneum, I have no tension. And that's why it's easy to close it, okay? So this is vitral, okay? And now you see that slowly you close and you reach the end of the peritoneum. And here, the posterior aspect is totally closed and remain an anterior thing. So I have to close the anterior peritoneum. You see very well the mesh. There is a good fixation with not a big tension. Avoid to place a big tension, just contraction, okay? And then we close the anterior place. And it's finished. So we don't let any drain most of the time. If you have stress incontinence, you can do at the end of the surgery a sling. You can place a sling by the vaginal access at the same time, okay? And it's finished, okay? So you see, in our hand, it's about less than 1 hour to do this surgery, okay? And there is no bowel preparation, okay? So what kind of exam before surgery? I always ask ultrasonography to have the aspect of the kidney, of the bladder, and of the size of the uterus. Why? Because it's a functional surgery, and I discovered three kidney cancer with prolapse. So you do a functional surgery, be aware that you have not another problem. So just generally ask for ultrasonography. Also because sometimes you don't know how huge is the uterus, and sometimes you will be in trouble with the uterus, and sometimes you have to do hysterectomy. I will show you. So you have to say to your patient, perhaps I have to do an hysterectomy. Okay? You have to ask to have a cervix examination. Okay? Because before the surgery, it's mandatory. Okay? And if the patient has big constipation, previously you have to ask a consultation with the gastroenterologist, MRI or endoscopy, because if she has a big constipation, probably it will be the only contraindication to place the posterior mesh. Okay? If you have a big constipation, I won't place the posterior mesh, because all the consultation after the patient will discuss about the constipation. Okay? And if you have a rectocell, you can deal with the vaginal access only for the rectocell. So in 95% I will do mesh anterior and posterior, even if you have no rectocell. Okay? But if you have constipation, pay attention. Ask if it's not a rectocell or a prolapse of the rectum, if it's different, if you have another problem, and avoid to place the mesh. And then the other exam, I asked for the urodynamic test before the surgery to be sure that there is no problem. Even if she has no incontinence, I won't place any stress, any sling, but I know that, for example, she has a lower pressure of the so I can say to the patient, perhaps you will have an incontinence after the surgery. You have about 10% of risk, but we can place a sling in another way. Okay, I won't place a sling if she has no stress incontinence or no incontinence during the examination while you push away the prolapse. Okay, so in our experience, it's about 60% of the prolapse with sling, and 40% without spleen, but the spleen can be placed in the second situation. And if you have incontinence after the surgery, in 90% with re-education, the incontinence will disappear. And if it's not okay, you place the spleen. Okay, so that's about the strategy for this surgery. Okay. So,
okay, thank you very much, Eric. I think that we can let a small time for questions if you want.
yes.
Just would like to talk about, to go back to the preoperative checking. One question and one comment. You talk about ultrasonography for checking of bladder and pelvic evaluation and kidney, of course. And what's the place of systematic MRI with dynamic pictures? Because now it's difficult to give a certification without MRI certification. Do you agree that it's becoming more and more frequently the standard
Exactly.
checking?
The MRI is right now the most standard.
Okay. So if you have MRI, you don't need ultrasonography.
What I need is
yes, but MRI it's abdominal.
So if you have MRI, it's enough. But you have to have an examination of your body. And right now the MRI in dynamic MRI it's the best, because there is no discussion. You see the MRI, you see the sister cell, and with pressure you see the externalization. So it's the best if you can have the MRI. The problem is to have the MRI. It's the best.
And my final comment, it's about the place of systematic urodynamic evaluation. As you know, it's not a recommendation, because we try to reduce the number of non-justified examination, and so it is considered that if we have no mechanical incontinence before, it's not an obligation to perform urodynamic evaluation before surgery. But you can prefer, but it's not
the recommendation.
A systematic recommendation.
Personally, I prefer to do it, because if you have any problem post-operatively, you won't say, oh, perhaps you had before a low pressure, we don't know. So I prefer to do it, but I totally agree, it's not a recommendation.
Okay, do you have some questions, comments? Yes, please.
That was the next